Today we are very honored to have Mr. Daniel Church, who is the Viral Hepatitis Coordinator with Massachusetts Department of Public Health, and Dr. James Morrill, who's the Primary Care Physician and Clinician-Educator at Massachusetts General Hospital Charlestown Healthcare Center. Today they are presenting Making an Impact on Hepatitis C in Your Health Centers. They will be focusing on the virus hepatitis C, which is the most common chronic bloodborne infection in the United States, and it chronically infects close to 3.2 million individuals. The objectives today will be understanding the history of hepatitis C, learning about the epidemiology, transmission, and screening of hepatitis C, hearing about updated guidelines for treatment and care for patients with hepatitis C, and discovering resources for providers. I'd like to give a short biography for each presenter. Mr. Dan Church is an epidemiologist and the Viral Hepatitis Coordinator with the Massachusetts Department of Public Health. He's involved in the development and implementation of disease surveillance activities, educational programs, and viral hepatitis prevention, testing, and medical management services. He is a member of the committee that authored the Institute of Medicine report, Hepatitis and Liver Cancer, 2010. He received his MPH from Boston University in 1997. Dr. James Morrill, who grew up in Lakeville, Connecticut, and majored in physics at Harvard College, graduating in summa cum laude 1992, had attended the MD-PhD program at Harvard Medical School from 1992 to 2001. He completed his PhD in neurobiology, focusing on the physiology of human brain and muscle ion channels. During graduate school, he served as a resident tutor in one of the Harvard undergraduate residential colleges. He became interested in primary care and community medicine during his final 2 years in medical school and completed the internal medicine primary care residency program at MGH in 2004. He now works as a primary care physician and clinician-educator based at the MGH Charlestown Healthcare Center with a particular interest in addiction and its medical consequences such as viral hepatitis. He, in addition to co-organizing and managing the outpatient addictions curriculum for MGH residents, he is clinical director of the MGH Community Hepatitis C program, which has introduced on-site hepatitis C treatment at the 3 MGH community health centers and maintains registries of patients with hepatitis C in the community served by MGH. He is a 2-time winner of the MGH Primary Care Teaching Award in 2005 and 2012, and a winner of the MGH Ambulatory Teaching Award in 2008. He has spent 5 years working part-time as a clinic physician at the Bay Cove Methadone Clinic in Boston, and he lives in Newtonville, Massachusetts, with his wife and 2 daughters. Mr. Dan Church, I leave it to you for the presentation.
Great, thank you so much for that introduction. And I guess, Jim, do you want to start by discussing?
Sure. Can everyone hear me okay? Who's on here? So this is Dr. James Morrill, and I'm pleased to be here with Dan to talk about chronic hepatitis C and what we can do in our community health centers. We felt this was quite a timely topic because hepatitis C is really emerging and is being increasingly recognized as a major public health issue and actually a community health issue. As we're recognizing there are large groups of patients with chronic hepatitis C who do not know they are infected, and that's led to some new screening recommendations, which you're going to learn about. There are younger groups of patients who are at risk for getting new infections with hepatitis C and are in fact getting new infections at an increasing rate, and you'll hear more about that as well. We're also learning more about the mortality due to hepatitis C and realizing that this is an increasingly deadly infection, so it's growing in importance in that way as well. And on the flip side, it's an exciting time for drug development for hepatitis C, where new therapies are being developed almost every year now with the promise of treatments that can cure the infection with many fewer side effects than the current treatments, and that could really open up treatment to a whole lot more patients at our community health centers. So it's a good time to learn about hepatitis C and know as much as we can. Our agenda today is on the slide in front of you now. What we'd like to do is I'll start by discussing some of the clinical aspects of hepatitis C. Dan will then jump in and tell you a lot about who has hepatitis C in our country, how it's transmitted, what the current recommendations are on who should be screened and how those recommendations are changing. I'll jump back in then and talk about antiviral treatment for hepatitis C and harm reduction for our patients with the chronic infection. And then we'll talk about some resources at the end for community health center physicians and providers. Okay, so I thought what we would start with is kind of putting our subject in context. Hepatitis C is one of 5 viral hepatitides. Yeah, and we can put them all up on the slide now. Hepatitis A, B, C, D, and E. And this kind of shows you what some of the differences are between these viral hepatitis viruses. Hepatitis A and hepatitis E are transmitted via fecal-oral transmission. Hepatitis A is seen in this country, but also seen at much higher frequency overseas. Hepatitis E is really not seen with much frequency in this country. Hepatitis B is a bloodborne hepatitis virus. Hepatitis C is a completely distinct bloodborne hepatitis virus. That's going to be the subject of our discussion today. And hepatitis D is sort of a cofactor virus that works only in concert with hepatitis B. And again, the bloodborne viruses B, C, and D are all genetically quite distinct from each other. And in turn, those are quite distinct from A and E, which are the fecal-oral viruses not transmitted generally by blood. So we'll be focusing on C today. So I thought what we would do is actually start with a case. And this was someone who I'd seen in my primary care clinic. It was a 65-year-old African-American male, actually a lawyer living in our community of Charlestown, who came in for a regular physical. He felt great. He had no complaints. His only medical history was a history of high blood pressure and a history of a couple of surgeries years ago, an appendectomy when he was a child, a young teenager, and a cholecystectomy 40 years prior at age 25. And the cholecystectomy was complicated by a hemorrhage requiring him to get a blood transfusion and go back to the operating room. In terms of his social history, he had used marijuana in college, but nothing recently, and had absolutely no history of any other illicit drug use, no IV drug use, no history of cocaine use, never had a history of unsupervised medication use. He was divorced, currently sexually active with a new female partner, had had a total of 5 lifetime sexual partners, all female. And at this initial visit, where I was just getting to know him, he requested a sexually transmitted disease screening, and has sort of sent the rally pack of HIV, serology, hepatitis B, syphilis, and hepatitis C testing. And to both of our surprises, hepatitis C antibody test came back positive. And that led to a couple of questions that he and I were addressing together, and these are the kinds of questions you're going to encounter when patients come back positive for hepatitis C at your community health centers. And the first is, what does it mean to have a diagnosis of hepatitis C? What's the significance of this infection? What do you do next in terms of testing? And then finally, what happens with hepatitis C? What is the clinical natural history of the infection? And we'll address those 3 points going forward. I also want you to think about that case as you hear Dan's part of the talk as well, and look back and think, what were this patient's risk factors for hepatitis C? Why should he have been screened for hepatitis C? Was it because of STI screening, or really are there some other risk factors that he has? And Dan will address that as we go forward and talk about screening later. Okay, so in terms of the clinical significance of hepatitis C, what do you tell patients when they come back positive? First thing I tell them is that hepatitis C is incredibly common. There are almost 4 million Americans who have a positive antibody test. As our speaker mentioned at the beginning, somewhere around 3.2 million actually have a positive viral load. Hepatitis C is now the most common cause of end-stage liver disease and liver cancer in this country. And the tough part about it is that a lot of people do not know they have the infection. It's estimated that less than half who are chronically infected are aware of their infection, and that's because of two factors. Number one, when you get the acute initial infection, usually there are no symptoms. That's true in about 80% of cases. And then about 80% of those acute infections progress kind of somewhat smoothly into chronic infection. So people can develop that chronic infection without knowing it. And in addition, a lot of those patients who don't know they have the infection, in fact, most of the patients infected got their infection several decades ago. They're part of this so-called baby boomer generation with a birth date between 1945 and 1965. And the problem with that is that that 2 to 3 decade time period over which they've had the infection is about how long it takes to develop cirrhosis, serious liver disease. It's liver scarring due to hepatitis C. And so a lot of these patients who don't know they have the infection are actually at this point in time starting to get sick from it due to their liver and are starting to come into our hospitals with severe liver disease and complications of severe liver disease, including decompensated liver failure and liver cancer. And so what we're seeing is a rise in hepatitis C-related mortality. This figure here on the slide is from a paper from last year which looked at death certificates and compared mortality due to HIV, hepatitis C, and hepatitis B in this country over time, showing this rise from 1999 to 2007. I'm sorry if the print's a little small on the slide, but hepatitis C is the middle, are the middle symbols. Mortality rising, HIV mortality dropping, and those two mortality curves crossed as of 2007, at which time hepatitis C mortality exceeded HIV mortality. So at this point, not only the most common bloodborne infection in the country, but the deadliest. So it's a fairly serious diagnosis and something we're taking a look at that mortality much more closely now. So what do you do when someone's diagnosed with hepatitis C? What are the tasks you have to work it up? Number one is you've got to figure out more about the infection. You've got to first make the diagnosis with a hepatitis C antibody test, go on to check some other parameters, including a hepatitis C viral load or RNA test, hepatitis C genotype, which characterizes the strain of the infection that you have, and that has a lot of significance for the treatment response. Excuse me, my computer monitor just turned off and just turned it back on. You also want to know about HIV status and hepatitis B status to make sure you know whether the patient is co-infected with one of those viruses as well as hepatitis C. And you want to know hepatitis B and hepatitis A status so that you know whether the patient needs to be vaccinated, whether they're immune or not. And if they're not immune to hepatitis A or hepatitis B, they need to get those vaccines because getting A or B on top of C can cause some pretty significant liver disease, acute liver disease. It's also very important to know their status in terms of cholesterol, blood sugar, and their body mass index, whether they have obesity or not, because those factors promote non-alcoholic fatty liver disease, which can be a cofactor that advances the scarring of the liver due to hepatitis C. And in fact, those factors can also make it more difficult to treat hepatitis C. So that initial set of things that you're testing are kind of telling you what kind of infection, what kind of hepatitis C infection they have, and what strain they have, which predicts treatment response, and then some other facts that are important to know to take care of them correctly. Next task is to do staging of the liver to figure out how much liver damage, liver disease they have already due to their hepatitis C infection. And this is important. Not only, this is important for all patients, but it's especially important for the baby boomers who maybe have had hepatitis C for 20 or 30 years and may have started to develop some scarring. So the things you're looking at there are ALT, is one of the transaminases looking at liver inflammation, the true markers of liver function, bilirubin, PT, and albumin. as looking at protein production. Many people check a baseline ultrasound, which can look for fatty liver and also look at the texture of the liver, look for any liver tumors or nodules. And then ultimately, it's important to get a true sense of how the liver is doing with some sort of histologic measurement. And that could either be a direct liver biopsy, a needle or core biopsy of the liver, usually under ultrasound guidance or sometimes CT guidance. Or there are some non-invasive blood panels that can give you a sense of how much scarring there is in the liver. And one example that we use at MGH is the HCV FibroSure test, which is a panel of 6 different blood tests that they sort of put together and come up with an estimate of how much scarring. And all of this testing is really to try to tell you about where the patient is in the natural history of the infection, from exposure, so that sort of the states that you go through in this infection are shown in this slide. Initially exposure, and then with an incubation period, and Dan, you can step through some of the other arrows that will appear on this slide. There's acute infection after the incubation period. As we discussed earlier, that's usually asymptomatic, but that's characterized by maybe a positive antibody, maybe not, because it takes somewhere from 6 to 12 weeks for the antibody to show up on the test, but definitely a positive viral load or RNA, and definitely elevated liver function test as the liver is inflamed. After acute infection, there's sort of a decision tree here. In a minority of cases, 15 to 25%, the virus can be cleared. That is more common with younger patients or female patients who get acute infection. It's actually more common in the small subset who have symptoms with their acute infection. That seems to be a sign that the immune system is kicking out the infection, and that gives you a higher rate of viral clearance. Most patients, however, many of whom do not have symptomatic acute infection, go into this state of chronic hepatitis C. That's about 75 to 85% of patients. And in that state, you do have a positive viral load. You do have some elevated liver markers because of ongoing inflammation. You do have a positive antibody. And it's in that state that the liver is smoldering along and over time gradually getting more and more scarring to the endpoint that happens in many cases of cirrhosis, which is pretty much full scarring of the liver. And then once someone has cirrhosis, there is about a 1 to 4% per year chance of developing decompensated liver disease, i.e. liver failure, or liver cancer, which are the dreaded and most deadly complications of cirrhosis. And what accelerates the process of cirrhosis and also the process of decompensation are factors such as concurrent alcohol use, a patient who has Hep C as an older male, and actually someone who contracted Hep C as an older male, they tend to progress more quickly. Hepatitis B or HIV co-infection with hepatitis C, those accelerate the development of cirrhosis. And then the factors I mentioned earlier that promote non-alcoholic fatty liver disease, those accelerate the transition to cirrhosis. So all of these things are important to take stock of when you're evaluating your patient. And I'll just quickly mention before turning it over to Dan that our patient that I introduced at the beginning turned out when we did a liver biopsy, which we went right for that liver biopsy rather than the non-invasive alternative because he'd had his infection for so long and we were concerned. We really wanted to find out if he could have advanced liver disease. Turned out he was about halfway there to cirrhosis. On our scale at MGH, we have a 6-point scale of fibrosis. 6 out of 6 is cirrhosis. He had about 3 out of 6. So he was someone who we caught sort of in the middle of this process. He did have active chronic infection, and he was progressing towards cirrhosis, but was not there yet. So as we'll talk about later, he was a good candidate to be treated. And now I'll turn it over to Dan for some more epidemiologic information.
Great. Thank you so much, Jim. So yeah, what I would like to talk about now is the epidemiology of hepatitis C and how it's transmitted. And a lot of what we know about hepatitis C prevalence is due to the ENHANE study, which is a study that's conducted by the Centers for Disease Control. And it's a population-based study, so it gives us some really good estimates, even if they tend to be a bit conservative. And from the most recent version of NHANES, it was found that about 1.5% of the entire U.S. population has evidence of past infection with hepatitis C virus. And when you look at particular demographic groups, you see that there's really some interesting differences. That first, about 2/3 of all cases are male. And if you specifically look at the people who were born between 1945 and 1965, as Dr. Morrill mentioned earlier, that's where about 2/3 of the cases are. 3.25% of all people born that are part of that age cohort have evidence of hepatitis C infection. When you look at, again, different demographics, non-Hispanic black males, 8% of them have been exposed in the past. White males, 4%, and Mexican American males, 3.4%. So there really does appear to be a lot more hepatitis C among males in that age cohort. But things are also changing, and I'm going to talk about that. But in looking at behavioral risks, injection drug use is clearly the most common and important risk factor for hepatitis C transmission. And studies have shown that 70 to 90% of people with any injection drug use history have already been exposed to hepatitis C. Another really very large population of where hepatitis C can be found is among incarcerated populations, where it's estimated that between 12 and 35% of all people who are incarcerated have evidence of past infection or current infection. And it's important to note that this is really due to community exposures and is not related to their incarceration directly. So how is hepatitis C transmitted? The most important thing to understand, of course, is that it's a bloodborne pathogen, so it's really blood-to-blood contact. And because, as Dr. Morrill was mentioning, hepatitis C is largely asymptomatic, and people are asymptomatic during the acute phase as well as through most of the chronic phase until the disease has progressed in most cases. But despite that, people can be infectious during that entire time. And again, injection drug use is the most important risk factor. And it's good to note that it's not just that the people are injecting drugs, it's that they're sharing drug injection equipment. And we're going to talk a little bit more about that. Another important thing is blood transfusions. People who receive blood transfusions or blood products or organ transplantation prior to 1992, when we were able to start screening the blood supply, are all considered at high risk for hepatitis C exposure. And this really goes back to the case that Dr. Morrill was mentioning earlier, who did have a history of surgery and blood transfusion from earlier in his life. I think it was about 40 years prior. So that would be a really likely way that someone could get exposed to hepatitis C. Chronic hemodialysis is also considered a very high risk, and that's largely due to non-sterile practices in the dialysis setting. Sexual transmission, which I'll talk about in a little more detail, is considered to be an inefficient way to transmit hepatitis C, but it is a possible way to transmit hepatitis C. Vertical transmission, which is transmission from the mother to the child during childbirth, results in about 4 to 7% of births to mothers who have hepatitis C infection going on to passing that infection on to the baby. If the mother is co-infected with HIV and hepatitis C, that risk of transmitting hepatitis C to the baby increases to about 20%. Oh, sorry. And among possible transmission risks, so there are a number of ways that people are concerned about, some of which are more of a risk than others. A lot of concern is held around occupational exposure. What really matters here is the likelihood of transmission. And if you're talking about a needle stick with a hollow bore needle that's contaminated with one of these viruses, you can see if that needle is contaminated with HIV and someone gets stuck, it's about a 0.3% chance that that will result in an infection for that individual. With hepatitis C, it's about 2%. And with hepatitis B, it's about 30%. So we can see that hepatitis B is obviously extremely infectious in blood. And hepatitis C is also, but certainly less so than hepatitis B, but certainly more so than HIV. So it certainly is a concern in the healthcare setting. However, the prevalence of hepatitis C among healthcare workers is really the same as the general population, and some of that, of course, is going to be due to other behavioral risks. There are often questions about transmission among household members, especially people who are sharing household items that can get contaminated with blood, such as nail clippers, razors, and that sort of thing. And there's certainly a plausible way that transmission can occur. However, it's not really believed to be an important factor in terms of transmission for the overall population. Intranasal drug use is a very controversial topic in some ways because we find that about 14% of non-injection drug users have evidence of hepatitis C infection. However, studies that have been done looking at drug use and hepatitis C find that once you control for injection drug use, most of the effect of people who are snorting drugs tends to disappear. So it probably does result in some transmission, especially if people are sharing straws and snorting when they've been snorting a lot and have ruptured nasal mucosa and can transmit from blood to blood that way. But it's probably not a very high volume way of transmission for hepatitis C. Tattooing and body piercing is another thing that we get a lot of questions on at the health department. And what's really important here is where they got their tattoo or their body piercing. And if they get it from a licensed facility, they should be practicing sterile methods to conduct their tattooing and body piercing. But if they were to get that in a correctional facility, for example, it would obviously be much more likely to have been a potential exposure to another bloodborne virus such as hepatitis C. So I'd like to talk a little bit about hepatitis C injection drug users because, again, that's really the most important risk factor for hepatitis C. And when you look just at new infections, about 68% of all new infections are due to to injection drug use. And when people start initiating injection drug use, people get exposed really quickly. And it can be as many as 32% within the first year of injection. And if you go out to 5 years of injecting behaviors, about 53% of people will be exposed to hepatitis C already. And one really key thing around injection drug use is that it's not only the sharing of syringes that exposes people to blood and to hepatitis C. It's really the sharing of any injection equipment that includes syringes, certainly, but also cookers, cottons, and any rinse water. Really anything that can get contaminated with blood is going to put a person at greater risk for being exposed to hepatitis C. And cookers, cottons, and rinse water have all been found to be independent risks for hepatitis C. So if you have a patient who is injecting drugs and is not sharing syringes because they've gotten that message about using a sterile syringe or their own syringe, but they are sharing those other things, they can still get exposed to hepatitis C and are very likely to. But it's important to note that even though it is very difficult to prevent hepatitis C because it is so infectious in blood and because you have to think of all these different factors, hepatitis C can be prevented among injection drug users, and there's increasing evidence showing that if you were providing access to sterile injection equipment in multi-component prevention programs that include testing for hepatitis C, education on how to inject safely, opiate replacement therapy, that hepatitis C can be prevented. And in fact, those numbers that I showed you before about how quickly people get exposed to hepatitis C after initiating injection practices, that is actually a lot better than it used to be. So we do have a window of opportunity to prevent hepatitis C once people start injecting. When looking at sexual transmission, again, it does occur, but it is very inefficiently transmitted this way. And studies that have looked at long-term monogamous partners where one person has hepatitis C and the other does not, over time there is a very low prevalence of hepatitis C in that other partner. And other studies that have also been done in very similar populations have shown even a smaller effect. So it really doesn't appear to happen very often. However, it's sort of curious because sexual transmission may account for up to 20% of acute and chronic infections in the United States, according to CDC. And the reason for that is because we have such a huge population. We have 3.9 million people with past exposure to hepatitis C, most of whom are sexually active. So even though each sexual encounter carries with it a very, very small risk of transmission, when you have so many different exposures over the population, it does result in a number of cases. Another really important thing to think about with sexual transmission of hepatitis C is the increase that has been seen among HIV-infected men who have sex with men in recent years. And this has largely been seen in the in urban areas and among men who are have multiple sexual partners. But it's really important message for people to be screened if they are living with HIV and are men who have sex with men who have multiple partners. It's really important that they get screened regularly and are told about the importance of protection with multiple sexual partners. So now I'd like to talk about what the screening recommendations are. And you can see these here. I'm not going to read them all. They make sense based on what we've already discussed. But what the biggest problem is with these is that they've only had limited success. As Dr. Morrill mentioned earlier, only about 50% of people living with hepatitis C are believed to have been diagnosed at this time. So we've had these recommendations in place since 1998. So we know that we've gotten a lot of people screened and a lot of people are in care, but we need to do a much better job, and this is not doing the trick, as it turns out. So CDC is now recommending, because of this huge population of the people born between 1945 and 1965 who have such a high prevalence of hepatitis C, they've recently recommended that there be a one-time hepatitis C screening for all people who are in that age group. And so this is another situation, and it's a one-time screening, and it really is not based on risk history at all. And so this is another situation where the case that we were discussing earlier that Dr. Morrill mentioned, this is another place. If this recommendation had been in place, he should have been automatically screened at that time, and it would have been a way of picking up on his hepatitis C infection in the absence of really analyzing his risk history. Another part of this new screening recommendation is the recommendation that alcohol use screening be conducted on anyone testing for hepatitis C, testing hepatitis C positive, and if treatment for alcohol use is needed, that people be referred to that. So I think this is going to be a really important recommendation. I think this really changes things in terms of how we get people diagnosed for hepatitis C. However, the risk-based screening, even though it has not been fully effective, is still really important, and I'm going to talk a little bit about why in just a moment. But first, the most important reason why this recommendation is being put in place, it goes back to these data that Dr. Morrill mentioned in his talk earlier, in that mortality for hepatitis C is increasing. And it has actually superseded HIV since 2007, and from talking to staff at CDC, this trend has continued and that gap is continuing to widen. So mortality is getting much worse with hepatitis C, not better, and that's why we need to screen people and get them into care. However, going back to that risk-based screening, that's going to still be important because we have a new epidemic of hepatitis C in many parts of this country. And in Massachusetts, where I work, we have since 2007 seen a really striking increase of hepatitis C among people between the ages of 15 and 25. And we're getting about 1,000 cases reported to us every year of hepatitis C, people who are newly diagnosed. And the case rate of diagnosis between 2002 and 2011 more than doubled in that age group. And the risk history information that we do have from our surveillance shows that this is largely due to young people who are injecting drugs, and most of them are injecting heroin. And unfortunately, other jurisdictions have also seen this trend, and that they're listed there, and I know that there are others as well. One of the big problems is we don't have very adequate surveillance for hepatitis C throughout the United States, so we're really only able to detect this trend in those states that do have adequate surveillance. So this could be a more widespread problem than we currently know that it is because we have no way of detecting it. But when you look just at the Massachusetts data, you can see that over time, the number of people, or the rate of people being diagnosed has increased among the 15 to 24-year-olds, and it's even higher if you extend that to 25. And all other age groups are declining in incidence in terms of diagnosis. And when you look at it this way, you can see in the 2002 graph that this is really the baby boomers who were being diagnosed and reported to us at that time. And you can see that it's about 2/3 male and 1/3 female, which is what we'd expect from the national data. But by 2009, you still were getting that population of baby boomers that were being reported to us, but you also had a totally different distribution, that you have another curve of these younger people who are being reported to us. And what's interesting about that also is that it's about a 50-50 split in terms of males and females. So it seems like a very different distribution in a lot of important ways. So now I'm going to turn this back over to Dr. Morrill to talk more about some of the treatment and care options.
Okay, thank you, Dan. So the question, once you've diagnosed your patient and done the workup and decided that they may be a good candidate for treatment, what's available to you currently to treat patients with hepatitis C? And the regimen that you use, is shown in this slide, depends on the genotype or strain of the virus that the patient has. My patient in the case had genotype 1, which is the most common strain of the virus. It accounts for about 75% of cases of hepatitis C in this country. So the current state-of-the-art regimen for him would be a backbone of 2 medications, something called pegylated interferon, or PEG interferon, which is a kind of an immunotherapy that is given once a week under the skin, subcutaneously. And in addition to that, it's an oral medication called ribavirin, which is given orally twice a day, about every 12 hours. And that's given for a time period of 24 to 48 weeks. On top of that now, and this is a new development in 2011, there is a third medication called a protease inhibitor, which is in the category of medications called a direct-acting antiviral medication, or DAA. And keep your eye on that concept, because that is sort of the category in which all of the new drug development is occurring, these direct-acting antivirals that sort of act outside of the traditional ways that the therapies that have been around for 10 years, PEG interferon and ribavirin, work. And for genotype 1 now, you use one of these protease inhibitors, and there are 2 of them, telaprevir and boceprevir, shown there in the table. And you use that at the beginning of the treatment course for about 12 weeks. And you can think of that as sort of a turbocharge or a booster to the backbone. The backbone gives you your basic treatment, but the protease inhibitor gives it more potency and makes it much more effective. And what the modern way of doing it includes is this idea of response-guided therapy. So you look at the patient's response to this regimen at 4 weeks, and you look again at 12 weeks. And depending on how the patient is doing, if they clear their virus quickly at 4 weeks, and if they keep their virus out of the system to 12 weeks, then you can shorten the treatment course, and it can be just 24 weeks, which is half a year. If they don't quite do that, but they are responding, then you go the full 48 weeks, which is a full year of treatment. And with this combination, backbone plus booster, the success rate is about 62 to 80%, depending on which medicine you're using, depending on your patient population, and depending on actually which study you look at. The way we measure success is SVR, sustained virologic response. And what that is a negative viral load 24 weeks or half a year after the end of treatment. So that, and that actually turns out to be a pretty good marker for cure of the virus. It really does not tend to come back at all if you've achieved negative viral load at that point. So those are pretty good numbers. It does involve a fairly complicated regimen of these 3 medications. If a patient has genotype 2 and 3, which is a minority of cases, the protease inhibitors are not necessary. In fact, they don't even work for genotypes 2 and 3, but you don't need them, because just the backbone, the PEG interferon and the ribavirin, this is looking at the lower part of this table, just for 24 weeks, and actually with lower doses of the ribavirin, gives you about an 80% SVR rate, 80% success rate. And that's, that means that actually in a lot of ways, genotypes 2 and 3 are with current therapies, still more treatable than genotype 1. But if you do this extra boosting with protease inhibitors for genotype 1, you can actually achieve pretty close to that 80% rate. The problem with current therapies is, of course, as probably many of you have heard from your patients, side effects. And these medications have really pretty significant side effects that inhibit a lot of patients from even starting therapy, and they inhibit a lot of patients from finishing therapy. And those include, for the PEG interferon, flu-like symptoms, which occur usually in the first 2 to 3 days after the injection of the medication, but also mood changes, neuropsychiatric symptoms, which can come from the interferon. And those can be anything from sleep disturbances to depression, sometimes even severe depression, anxiety, irritability, and things that can be just as difficult as physical symptoms and can really affect people's quality of life during treatment. In addition to all that, there are some medical things that the physicians are following, such as low blood counts, pancytopenia, so white blood cells, red blood cells, and platelets all go down. The marrow is suppressed. Ribavirin adds to that what's called a hemolytic anemia, where red blood cells are getting kind of chewed up in the periphery. So that lowers the red blood cell count further, so patients can get quite anemic. And also, I should mention, the PEG interferon can promote autoimmune phenomena. So if someone has a pre-existing history of rheumatoid arthritis or psoriasis, that can get much, much worse on treatment because, in a way, these regimens they're not immunosuppressive. They're actually immune promoting. That's one of the ways that interferon works and kicks out the virus, is by goosing up the immune system. So if there's an autoimmune phenomenon, that can get worse. Also, I should mention, ribavirin is quite teratogenic, so that's a potential a significant harm due to that medication. You have to make absolutely sure that young female patients of childbearing age are screened for pregnancy and have significant effective contraception in place before starting therapy. Protease inhibitors also add some side effects. It actually turns out the anemia is worse when you add the protease inhibitor to the regimen. Something that's really been in the news lately is the severe rash due to the protease inhibitor telaprevir, which now has a black box warning about it. And we do see that sometimes it can be quite severe, and in rare cases, life-threatening. In almost all patients, they get itchy, and they get itchy all over their body. Sometimes there's perirectal itchiness, which is a tough symptom for patients to tolerate. And then dysgeusia, which is more with boceprevir, which is just a sort of a sour or bad taste in the mouth. So what's coming next? So Dan, if you press that space bar. So what's coming is more of these direct-acting antivirals. This is where the drug development is. So more protease inhibitors of various kinds. Another target called NS5A, which is another viral protein. There are some inhibitors of that protein is involved in viral assembly. And then polymerase inhibitors. And the one that's been kind of hot in the news lately is something called sofosbuvir. There's a big paper in the New England Journal of Medicine just last month, which showed tremendously high success rates using sofosbuvir, this polymerase inhibitor, along with ribavirin without PEG interferon. And that's really where we're all going with this. That's the point of all this, actually, is the holy grail of getting to interferon-free regimens. Because if you look at the side effect column in this graph, actually a lot of those side effects, and the ones that patients have the hardest time tolerating and are most scared about, come from interferon, come from pegylated interferon. So if we can come up with regimens that do not include that medication, even if they're somewhat complicated and have several medications, we've gone a long way to getting more people onto treatment and getting more people through treatment. And what it's looking like now is that for genotypes 2 and 3, we may have an interferon-free regimen that actually includes this sofosbuvir and ribavirin, but no interferon, that may be close to 100% effective based on the existing studies that we have within a year or two. So that's really where we're going with all this. So that's something that you should know and can tell your patients as you're diagnosing them with hepatitis C, doing careful workups, that better treatment is coming and new developments are happening all the time. And the last thing I'll just mention is that there is some work being done on what you might call pharmacogenetics, different genetic differences between patients that affect how they respond to in particular interferon-based therapies. And there's something called IL-28B polymorphisms, genetic differences that patients have that where their genotype sort of determines how interferon responsive they will be from the get-go. That may become less important as we have more patients treated with interferon-free regimens, which would be great. So moving on, I just wanted to say a few words about how you decide whether a patient is a good patient for getting treated. And I'll just say that it's important to know, factors that might lead you to treat someone would be they have to have an active infection, positive viral load. You'd want to see evidence of chronic hepatitis, and I think a patient becomes a better treatment candidate if they have some fibrosis, because that means that they're on the way to cirrhosis and you can catch them before they get there, but they're not right at the beginning of their infection. They have to have compensated liver disease so that they don't have splenomegaly and low blood counts on that basis at the outset. They have to have kidneys okay and blood counts okay, no other causes of anemia or low white blood cells or platelets. And then I think probably most importantly, or as importantly, they have to be ready to go through a complicated treatment regimen and adhere to all that's expected of them. Patients who really shouldn't be treated are those who have factors that are going to be made worse by the treatment regimen, such as depression. If they have uncontrolled or untreated depression. They have treated depression, that's okay, but if it's untreated, that's a significant contraindication. Autoimmune disease, as I mentioned. Alcohol use is an important one because using alcohol concurrently with treatment really inhibits the effectiveness of treatment and essentially renders it almost useless and causes more liver inflammation. So that's a really, really important one. Ongoing drug use, not mentioned in this bubble, but that's not a strict contraindication and something to be thought about as perhaps a relative contraindication or a barrier that you can overcome even if the patient is kind of relapsing, and we'll talk about that in a second. Pregnancy, so that's why you need to use the contraception because of the teratogenic nature of ribavirin. Other medical diseases that would make treatment dangerous, such as severe heart disease, so they couldn't tolerate anemia, or seizure disorder. Seizures are actually promoted by pegylated interferon. And then, of course, allergies to medications. And then the third bubble up top are the sort of the gray zones, the times when you really have to think about your patient. There may be some barriers, but maybe you can overcome those barriers. And this might be a patient who tried treatment before and couldn't tolerate the side effects. Someone who is actually actively using drugs, that's an issue where actually there have been a number of studies showing effective treatment in active drug users. Just have to have the right infrastructure around them and the right treatment program around them, and you can do it in many cases, but you have to make sure the patient really can follow up. Psychiatric disease that is, I would say, quasi-stable, so the patient is on medication and has been treated, but may sometimes be unstable. That's something that just requires good psychiatric follow-up. And then issues with housing, clinic follow-up, and other factors that could affect follow-up for lab work and for treatment visits. Decompensated cirrhosis, there are protocols for treating patients with that degree of cirrhosis, although that's more difficult to do because of the blood counts and liver function, metabolism of the medications. And then an interesting factor now is whether to treat genotypes 2 and 3 now, or because of sofosbuvir and other direct-acting antivirals, maybe waiting and holding those patients, taking care of them, reducing harm, and getting them ready for interferon-free treatment in the near future. So that's an individual decision there. And I put a question mark in the middle because these are the things you're actively considering when faced with the patient. So I'm going to quickly go through this slide. This is some data looking at barriers to treatment in 2 groups of patients that we've seen at MGH Charlestown. We also, like Dan, at the state level and our very local community level, saw really 2 peaks in the age distribution of hepatitis C patients at our health center because there's a lot of IV drug use here among young patients. We saw not only the baby boomers, but also this young emerging peak of newer cases of hep C. And so we looked at barriers to treatment in the young adult patients, those are in the dark blue bars, versus the older adult patients, and we found that there were many more barriers among the younger adults. They were much less often referred for treatment, much less often made it for a pre-treatment visit, much less often got treated, completed treatment, or had success. In fact, none of the young adults at the time of this study, which was about 1.5 years ago, had completed treatment and had success. And if you look at the reasons, the next panel of this slide looks at the reasons patients weren't treated, of those who were not treated. It's really interesting to see the different reasons for non-treatment among young adults versus older adults at our health center. And for the younger adults, it was things like, active unregulated substance abuse, not in care, loss to follow-up, or even no identified reason. For the older adults, it was more kind of reasons for deferment, like, and there were fewer of those untreated patients among the older adults, but it was reasons like the patient didn't want to be treated, so patient preference, waiting for new treatment regimens, for example, those genotype 2 and 3s that I mentioned, not enough fibrosis to warrant getting treated, or having some medical reason or psychiatric reason that there was a contraindication for treatment. So one of the ways we think about this is that among the younger adults, there were more surmountable barriers to treatment. And so then the question is, how do you get the patients who are medically appropriate for treatment, how do you overcome those barriers and create a system that will get more patients treated? And I think this is something in community health centers that we need to continue to think about. So for those who can't be treated, what do? You have to continue to think about harm reduction. And I think of harm reduction as something that primary care systems and community health centers do very well. It includes things like making sure everyone's vaccinated, no one's drinking alcohol who has chronic hepatitis C, avoiding meds that hurt the liver, or over-the-counter products, which are a big factor there, can be a big factor, particularly Tylenol-containing products, herbal products, making sure that patients know about hepatitis C, are fully educated, know all the stuff that Dan has been teaching us about transmission and know how to prevent transmission, that if they have psychiatric disease or addictive disorder, that they're in treatment for that, and that if they in fact have cirrhosis, especially advanced cirrhosis, that they are referred to hepatology, and that as the primary care system and the primary care physician, you're working with the liver doctor to keep their liver safe and doing liver cancer screening, making sure they're on diuretics and all the right medications for their liver disease. So this should be part of the background. And I think there's special harm reduction to think about for intravenous drug users. And Dan has already gone over some of this in some detail, but to mention again, I mean, it's important that they are provided with education on drug treatment, that they're provided with access to clean needles through needle exchange programs. In Massachusetts, they can get clean needles at the pharmacy without a prescription now. And at needle exchanges in our city and state, they can get clean works as well, other apparatus, so that they're not sharing water or cookers or cottons. And yes, further harm reduction education about safe injection practices, and then getting them into opioid replacement therapy, working on overdose prevention. All of those things are really important harm reduction pieces for intravenous drug users, in particular with hepatitis C. We should be doing all these things in the background. And so just quickly, I'll page through this, that there are really 4 main tasks. There's a lot, actually, that we are responsible for with respect to our hepatitis C patients, not only identifying, characterizing the infection and doing the workup, doing harm reduction, which is something we've mentioned in the previous slide, which is something we do quite well generally in primary care and need to do with this disease as well, co-managing advanced liver disease with specialists, and then I think a special one is to think about what the barriers to treatment are, for example, in our young patients at MGH Charlestown, and then really try to overcome the surmountable barriers and get patients treated when possible. I just wanted to close with mentioning a couple of examples of projects that have helped primary care systems do these things. And one of them is something called Project ECHO, which is something you may have heard of, which is a fascinating project out in New Mexico using telemedicine to help promote hepatitis C treatment in primary care practices, actually mostly community health centers, 21 rural sites, often 200 or more miles from the mothership of the University of New Mexico, These sites were hooked in, key personnel were identified, and they were hooked in by telemedicine to specialists at the main hospital. And they formed what they called knowledge networks between the specialists and the primary care physicians to disseminate best practices. And basically there was a study in 2011 showing equivalent, in fact just slightly better success rates of treatment out in the primary care practices enabled via this telemedicine compared with those treated centrally at the University of New Mexico. So this was a real coup for primary care-based treatment. And also side effects profiles and dropout rates were lower in the primary care practices, probably because their doctors really knew their patients, as you do at community health centers. And then the final thing, just to show, at MGH we're trying to do something somewhat similar with a program that involves on-site care at the health centers, health center registries, so understanding our populations of hepatitis C and feeding that back to enable better care, doing education and screening in the community, working with specialists to form these sorts of knowledge networks, and then bringing specialists in the community together so that community members have access to studies, for example, and study drugs, and the specialists know more about their communities. So now I'll turn it back over to Dan to talk about a few resources.
Great, thank you so much. So I know we're running late, and I do apologize for that. We had so much information to go over. So I just want to quickly tell you some of the resources that are out there for some of the questions you may not be able to ask this time that may be able to get you the information you need. First of all, for providers, CDC has a lot of great information from data to recommendations, and they are going to have some updated slide sets available soon. They also fund the hepatitis web study, which provides interactive case-based modules and free continuing education credits. The National Training Center for Integrated Hepatitis, HIV, and STD Prevention Services provides free access to training videos and webinars on a range of topics. Treatment Action Group is an organization that provides, among other things, summaries of the hepatitis drugs that are in the treatment pipeline. So if you want some more information about some of the medications that Dr. Morrill was talking about, that's a great resource. Caring Ambassadors Program for Hepatitis C, if you go to their website, they provide a monthly newsletter that you can sign up for. It's free and provides a really detailed summary of all the research that's published in the prior month. So every month they send this out, and it summarizes everything and provides abstracts and links to those articles. So if you want to keep up with how things are changing with hepatitis, that's a really excellent resource to consider, and it's free. In terms of patient education, CDC also has a lot of really excellent patient education materials that they've developed very recently. They have this new campaign called No Hepatitis, and they are continuing to add new materials and in other languages as much as they are able to, and you can order limited quantities for free. The Harm Reduction Coalition is a good resource if you have patients who are actively using drugs. It has great hepatitis prevention information. The Hepatitis C Support Project has good low literacy information, as well as just patient education on a range of different hepatitis topics. The Treatment Action Group, which I mentioned before, does provide a guide to how to get involved with hepatitis C clinical trials, which, if you have patients that are interested in doing so, is a good place for them to start. The Caring Ambassadors Program, which I also mentioned before, does have information on the impact that complementary therapies can have, as well as other information for patients that may be very useful for the people you're working with. And then finally, in terms of policy, if you're interested in learning more, what is happening nationally to address hepatitis C, the U.S. Department of Health and Human Services released the very first Viral Hepatitis Action Plan in 2011, which provides a real roadmap for how to address hepatitis in the United States. And the Institute of Medicine report on hepatitis and liver cancer also provides recommendations for how we need to change what we're doing in order to address these epidemics. And then finally, if you're interested in getting involved with advocacy and education at the national level, the National Viral Hepatitis Roundtable is the leading organization doing national advocacy, and if you or your organization is interested in getting involved in that to help try to gain support for the patients that you're seeing, I would certainly recommend that you visit their website. And this is the contact information for both myself and Dr. Morrill, and if we'd be happy to hear from you if you have questions that we're not going to be able to answer on this webinar, and I hope that we've been able to provide some information that's going to be helpful for you in trying to address both the epidemic of hepatitis C among baby boomer populations as well as this emerging epidemic of hepatitis C in young drug users.
Yes, thank you.
So I don't know if there are any questions.
I'd be happy to answer questions if there's time.
Oh, hi there. Sorry. Yes, we have several questions. Are pharmaceutical companies working on an HCV vaccine? How far off would you predict we are away from obtaining an effective vaccine for hepatitis C?
Dan, do you know anything about that?
Well, I know that there is some research that is going on in that regard, but I know that there's really no timeline on this, and I think there is some slightly more promising information. I think for many years there's really been nothing that has looked very promising, and I think more recent information shows that there is some work being done in this area that is looking up, but there's really no timeline at this point, and we're certainly many years away from that.
Yeah, I think I'm definitely not an expert in that field, but what I understand is that there was a breakthrough a few years ago in terms of growing the virus in cell culture, which was a huge barrier for a long time. So I think that barrier's been crossed, but the other problem is the virus is very mutagenic. It has a very high mutation rate. So that's one of the reasons why a vaccine has been quite elusive, and they have not yet been able to get around that. Exactly how many years off they are, I'm not sure. I don't know either.
Okay, thank you. Since you were talking about that there's baby boomers that have these infections, are there Medicare covered services for hepatitis C screening prevention?
Well, one of the big issues with the recommendation on the baby boomer screening is that the U.S. Preventative Services Task Force recently released their draft recommendations, and they gave the baby boomer screening for hepatitis C a C rating, meaning that it would not be required to be covered as one of the essential preventative health screenings, which you need an A or B rating for. So that's still in draft, and I know that there was a pretty big response to that, and we're waiting to get their final recommendations on that, and that should be coming out this year, although they have not said exactly when, but I think it's likely to be around May or June from what I've heard. But I think that's really going to determine how easily it is to get those screenings paid for. Although I've also found that with certainly in Massachusetts, with our Medicaid program, there isn't a specific allowance for that, but it's, with the hepatitis C screening, the antibody screening is so inexpensive, essentially if the provider orders it because they believe that the patient is at risk, without having to define what that risk is, it will still be covered. And so there's probably going to be a range of different experiences across the country in terms of how easily and well that's going to be covered. But it will also change depending on what happens with the U.S. Preventative Services Task Force.
Yeah, one quick thing to add there is I have been asking some of the specialists here at MGH about how to get it covered in someone who really doesn't have any overt risk factors that they've admitted or that the physician has uncovered, and you're just screening because they're a baby boomer. And some of the and some of my colleagues have asked about this as primary care physicians. The specialists have suggested using the code V01.79, which is a generic code for exposure to viral disease, as a way of getting it covered. And I don't have closed-loop feedback on whether that's been working in all cases, but I've used it a few times and my colleagues have as well.
Okay, Linda Boddick has her hand raised. She's going to ask verbally her question.
Sure. I'm sorry, I'm not currently hearing a question. It may be coming.
I do see that there is a question that someone typed in here. It's, can superinfection with more than one genotype of HCV occur? Dr. Morrill, do you want to?
Sure. Yeah, that's a question I've asked of specialists before and have encountered that before. Extremely rarely you will see a genotype assay come back as a double genotype or an indeterminate genotype. But usually what happens, and what I'm told happens, is that a particular viral agent, a particular strain will take hold and for reasons that are not fully understood will set up, sort of set up shop and prevent other viruses, other individual viral strains from taking hold. So that if genotype 1 is there, even if there's a reinfection with another genotype from an exposure, for example, a needle exposure, it cannot take hold because there's an existing infection. So that appears to be a biological way that one infection boxes out others. But I have to say occasionally, and I think this may also be genetic mixing at the level of genotypes and genetic diversity, you will get an indeterminate or double result on your genotype assay.
Here's another question. What's the prevalence of if you're being treated for hepatitis C and you continue to either have sexual relations or using IV drugs, what's the prevalence of transmitting that the virus while being treated and then after treatment is finished?
Great question. I'll say a word about this and then see if Dan has other thoughts about this as well. I think it's generally agreed that during treatment you are essentially being prophylaxed, protected against getting a new infection. The same treatments that are used for chronic infection are actually the ones that are used for acute early infections. And if you caught someone who had just contracted the infection in the first few months and they were judged to have acute or early hep C, you would give them right now under current therapies, you'd give them pegylated interferon and ribavirin just for 3 months with like a 90% cure rate. So it's actually quite easy to treat early infection. And essentially, you'd be doing that by having the medications on board if someone is using and relapsing during treatment. So that they should not be able to contract it while they're on therapy. But post-therapy, it's absolutely possible for them to get a second infection or even a third infection. And I've had a couple of patients who have been treated more than once, maybe by a previous provider and then once by me, and have gotten a new hepatitis C infection. I've had several patients also who actually cleared the infection themselves and then got a new infection on top of that, unfortunately, that they didn't clear and had chronic infection. So, and that's an important point that I didn't make a big deal of in the talk, but that the antibody that you use to detect the infection and exposure to the infection is not a protective antibody. And this differs from hepatitis B, where hepatitis B surface antibody indicates immunity and protection from getting infection in the future. For hepatitis B, for hepatitis C, excuse me, the hepatitis C antibody does not confer any protection. If you've been exposed, you can still get the infection again.
And then a question is, how are you able to fund testing and treatment for low-income uninsured patients?
Good question. I'll say one thing. Uninsured is a very difficult issue that fortunately in Massachusetts we've had less and less of that issue to deal with because of our Massachusetts insurance program, which has now really expanded insurance to most people in the state. And we also have a very good safety net program here. Our Medicaid program, Mass Health, is excellent in terms of, speaking from a primary care doctor's point of view, in terms of what it covers. And I will say that it very smoothly and easily covers testing and full treatment with these expensive medications, including protease inhibitors. You have to file a prior authorization form and justify why the patient is a good treatment candidate, but they readily cover the medications. And Mass Health really covers people at the lower end of the income scale here in Massachusetts. And so a lot of what we're doing is trying to get patients onto Mass Health. And so we kind of have to try active ways of doing that, and then they can get the medications covered. But I think this is true, and I'm not an expert on this, but in other states there are more patients who really truly face severe underinsurance or lack of insurance. And I think that's a more difficult problem.
Okay.
Hi, and this is Dan, and I really think that this is going to change as the Affordable Care Act becomes more implemented across the country. I think it's, the ACA is based on the health insurance program in Massachusetts, and so I think we've had a pretty good experience here with getting the care covered that people need, although the demand for treatment has not been as high as we would think. In terms of the numbers of people who have hepatitis C. So I think as the medications become easier to tolerate, as Dr. Morrill was talking, I think that is going to change things in terms of the numbers of people who are going to go on treatment, and that may have an impact on what is going to be able to be covered nationally under the Affordable Care Act.
They will likely be expensive.
Yes, indeed. Okay, so you may have answered this question, but are most insurance companies or all insurance companies paying for the new protease inhibitors, and do you have difficulty with Medicaid and your Medicare agencies covering the new protease inhibitors?
I have had no trouble with these companies covering them. There are varying degrees of, physician justification that is required. I've run into the roadblock, and as primary care physicians who gain expertise in this do treatment, that I'm not a specialist. I'm a primary care physician doing this treatment. So, but that's been a surmountable barrier because I've just been able to sort of write a letter saying that I've treated this many patients and I have this experience and feel qualified and have the track record to do this treatment, and then it has gotten approved after that, attesting to that. But with varying hurdles you have to jump over, every private insurance that I've dealt with, Medicare D plans and our Medicaid program here in Massachusetts have all covered the medications. One other factor I'll mention is that sometimes, especially with private insurance, co-pays are quite high, on the order of $40 to $60 that the patient would have to come up with, and sometimes even higher per month. But for patients who are low income, faced with those kinds of co-pays, we've come across a couple of foundations that have helped us meet those co-pays through charitable sources. So those are out there. And I actually don't have the names of those foundations in front of me. If there's a way for me to feed those back later, I can do that. I would expect that some of the resources that Dan mentioned would probably have links to those charitable foundations.
Okay. You had mentioned HHS was putting together a hepatitis C pathway. Are there government resources or funding out there specific to hepatitis C prevention? And is there a major priority for the funding agencies, for these funding agencies?
I'll address that. Unfortunately, no. The answer is really the amount of funding that is available from federal sources to address this huge epidemic that is causing so much morbidity and mortality is really sort of shockingly limited. That the CDC in their Center for HIV, Hepatitis, TB, and STD prevention and control, the viral hepatitis division gets 2% of the budget compared to 70% for HIV. So they're getting now, I think it's about $30 million annually to provide prevention and screening money throughout the country, which, as anyone on this call can understand, really doesn't go very far. They did just put out some new dollars for some hepatitis screening and linkage to care programs, but that's a very small number of programs at very modest amounts that were being funded. So at this time, there's really very little that is being done by the federal government to address this, other than putting out some really good recommendations and good information. When it comes to surveillance, that's also something that's really greatly underfunded throughout the country. And most states do not have adequate surveillance, so it can be very difficult from state to state to know what exactly the epidemic looks like and what the priorities should be. So I think we still have a lot of big barriers to overcome, and I think that the good news is that there is a good public health infrastructure to build on. In Massachusetts, where we no longer have any direct funding for hepatitis C services, we've been able to build with our state HIV dollars on our HIV counseling and testing programs so that we can provide testing for hepatitis C and programs that are already working with those populations, including many community health centers, so primarily community health centers, as well as to try to provide some medical management programs in the context of Ryan White-funded HIV programs, but for people who are mono-infected with hepatitis C. So I think many states are trying to be as innovative as possible, but the amount of funding from the federal level to support this is extremely limited. And I think that there will be more opportunities to do more, especially at the community health center level, as the Affordable Care Act gets implemented, given its focus on community health centers.
Okay. One last question. Are the protease inhibitors offered through the medication assistant programs from the pharmaceutical companies who make them?
I believe there are medication assistance programs. I have not had to tap into that yet in my experience. I've treated now since mid-2011 probably about 12 patients using those medications, and all of them had enough coverage. I think we did have to use charitable organizations separate from the pharmaceutical company for copays on 1 or 2 patients, but I'm sorry, I don't have a detailed knowledge of that. I do believe, though, that, for example, Vertex, which makes telaprevir, the one we've used actually more is telaprevir, although they both are important, boceprevir and telaprevir has the rash, so people are moving toward boceprevir more. But telaprevir and Vertex, I believe there is a compassionate care program that Vertex has.
Yeah, but Dr. Morrill, I can also see that there are compassionate care programs from all of the companies that are making hepatitis drugs at this time, and some of my understanding from some of my colleagues who are hepatitis coordinators in other states is that, especially for states that do not have healthcare reform the way we do in Massachusetts, those have been extremely helpful and tend to be fairly generous programs and pretty well managed. So that's definitely a good resource for some patients.
Okay, gentlemen, I would like to thank Mr. Dan Church from the Massachusetts Department of Public Health and Dr. James Morrill from the Massachusetts General Hospital Charlestown Healthcare Center. This has been a wonderful webinar. This presentation has been very informational, and I'd like to thank all the attendees for coming. You make a huge difference in all the community health centers across the country, and we thank you for what you do. We'd like to announce June 4th through June 6th, we are co-hosting with the Community Health Part for Sustainability, our 2013 Health Centers and Public Housing National Symposium. The theme is Keys to Health Center Success. And if you would like to still submit an abstract, our deadline is February 19th. And if you have any questions about the upcoming symposium, please contact me at the web address on the slide, or you can phone or you can telephone me at the phone number on the slide. With that, I would like to say thank you very, very much to the presenters, and if you have any questions about training or technical support, please call any one of us at North American Management. We are here to help you with anything that you need. And with that, I thank you very much.
Thank you.
Yeah, thanks very much.
Okay, bye.
Thank you, Mr. Church. Thank you, Dr. Morrill.
Thank you so much. Thank you. And Dan, take care.